any discussion with the word naked in the beginning sort of gets all of our attention, or maybe it was the profiteering word. I don't know. Ironically, Passar came up with this title, which I thought was sort of genius. And then shortly after that, Dr. Jim Kahn was describing profiteers as wolves in sheep's clothing. And then shortly after that, Dr. Susan Rogers said, yes, and the wolves change clothes all the time. And then I realized that that's kind of what we're talking about here, is not just changing clothes, but some of this is getting pretty blatant and bare. So, I'm a Medicare member, and it's a really important thing to me. So I am delighted to have groups like Passara focus so strongly on this. So we're going to run through some of the current landscape before we kind of unpack the attacks on Medicare through profiteers. We will explain sort of part of the reason why I think Medicare is so incredibly important. Then we'll go through some of the attacks, and then finally end up on, what do we do? What are we proposing as sort of next steps in today's political landscape? So start with a piece of news in case you missed it. Here's a healthcare reform that was described as a milestone in finding better ways to improve well-being. Who doesn't want that? And specifically, a financial incentive to keep subscribers healthy, shift the emphasis to the prevention of illnesses, test in all parts of the country, and test in medically underprivileged. That kind of shows how dated that is, because indeed this is from the HMO Act. And I'm pointing this out to say that I believe that the value proposition of the HMO Act from 1973 we will align money so that people want to keep, so that payers like the insurance companies want to keep people healthier. That value proposition has carried through to the things you heard Karen talking about with ACO Reach, and we will unpack that more. So this is one of my few wonky charts, and bear with me. I think you can follow this. It's kind of dense, but let me walk you through this. And I promise you, I won't make you go this dense again very, very many times. So this is no surprise to you. This is life expectancy vertically and healthcare expense horizontally. And as you can see, each one of these lines, different colored lines, is a different country. It's a different country. So you can follow the blue one or the brown one, and you'll see that back in 1970, countries were averaging, 71 years of life expectancy at birth. And over the past 50 years, 2020 in the top of this chart, you'll see that most countries have gained several years in life expectancy. The data stops at the start of the pandemic. I'm sure that next year, if we do this, it'll be a little bit different, but they stop like that. So you might be sort of wondering which of these 30 countries, each line is a different country, which one of those is the United States, and you'd find it's a trick question, because actually the United States wasn't in that data set. Indeed, here we are differently, and there's some things to notice. The first most obvious piece is that here we are in 2020, spending twice as much per person and living several years shorter. Our lives are shorter than these other countries that spend half of what we spend. That's the first obvious thing to notice. And then the second thing to notice is way back in 1970, we weren't an outlier. we were normal. We were in the middle of the pack, so to speak, sort of, and we have migrated away. So what pulled us away? Well, all of those countries over there have in common some form of national health insurance. It's different in every country, but they all have some form of ensuring that everybody in their country has access to affordable, high quality care. And we, of course, have yet to accomplish that. But it's not that we've been sitting idly by. No, over these 50 years, we've tried a number of different models, starting, perhaps with the HMO Act that we sort of began this talk with, and then migrating through. Some of the models here are things you're familiar with, and some perhaps not so much. But each one of these models, the point I made a moment ago, each one of these models has as its core putting a financial intermediary between us and healthcare. They each have some version of that. Our models rely on markets. Every one of these models is market-driven and enables, frankly, the profiteering that we're going to be unpacking more today. So why focus on Medicare? Why do we care so much about Medicare? And I know you all know basically the basics of it, but there are 4 key features that I don't think people have heard enough about that we will correct. You will hear enough about them in a moment. So the first is that Medicare is responsible for the fact that American hospitals are desegregated. And I'll show you an example of that. Medicare also has the fewest barriers and the broadest networks of any healthcare system in the country. It's incredibly lean and efficient, making good use of our dollars. And most strikingly to me is the effect it has on our life expectancy that people, I don't think, quite give it the full credit for. So in case you're not familiar with this book, it's the only book I'll point out tonight, but you should have a look at this book, The Power to Heal. And it talks about how the Civil Rights Act passing in 1964 made it illegal to have a federally funded program in a segregated institution. And indeed, it was because of that, and then thousands of people volunteering to make sure it was being implemented accordingly, that when Medicare was enacted in 1965, if a hospital wanted to take federal funds, they had to stop having segregated units. And indeed, that was very common. It was very common to have the colored waiting room. And here's just sort of one person who was a child before Medicare was enacted, and she was admitted to Michael Reese Hospital's segregated unit. Why am I telling, when she got sick as a child, why am I telling you about her? Because that was before Medicare, and now look at her. She became the president of the medical staff at the hospital that wouldn't let her be in anything but the segregated unit. So Medicare, and I don't know if you know her, Claudia Fagan, wonderful human being. So Medicare is the reason that our hospitals became desegregated, sort of as an outgrowth of the Civil Rights Act. So secondly, Medicare has the broadest networks of any insurance company in the country. If you ask, as Kaiser did not too long ago, a few months ago, 90% of office-based non-pediatric physicians will accept Medicare as a payment model. I behoove you to find a similar plan that isn't Medicare. If you live in Seattle, good luck finding non-emergent care being covered for you when you're on vacation here in St. Louis. It won't happen. So 90%, they don't all take new patients because not all physicians are accepting new patients, but 90% accept Medicare as a payment model, and even vastly higher for surgical specialists. So with Medicare, you can go to almost every doctor in the country. It's lean, it's efficient, and if you just look at how health insurance has become more expensive over this 10-year period here, it's grown per person by 53%, whereas Medicare's cost inflation is less than half. So it really has done a splendid job of keeping down the cost of healthcare. And it does that with a remarkably efficient system. It has a 2% overhead, and we'll come back to that, but it's pretty hard to imagine a more efficient way to run a healthcare system. And what's the thing that we most want from a healthcare system? We want to be healthier, right? And so here's my second wonky chart. I think it's the last wonky chart, so bear with me on this. This is looking at mortality rates by age, so compared to 17 other peer nations. I think of it as life expectancy, but really this data is mortality rates. And so this is us versus 17 peer nations. And you can put your head up to your monitor and have a good look and see what the countries are. It's down there on the bottom left-hand corner. Any of my charts that have, or slides that have data, there will be a reference at the bottom left-hand corner, the peer-reviewed public domain type things. So here we are doing the worst of 17 countries, literally with the worst mortality rate by age, from children to the left to our most seniors on the right. The worst, despite spending twice as much. And then what happens that you don't see in other charts is that we turn 65, and country by country, year by year, we climb to literally the best in the world. So we've got a really good delivery system. We have many of the world's best doctors and hospitals and nurses and pharmacists and such. We just don't let everybody in until they turn 65. So 2% overhead, what does that mean? It means it's just really lean and efficient. And so it's sort of a simplified cartoon, but there we are on the left, we pay our taxes and we get our little red, white, and blue Medicare card, and then there's healthcare stuff that we want. Medicare Advantage, the first of the attacks that we'll talk about profiteering, attacking Medicare, is completely different. And it's appropriate for this to be the first attack to talk about, because Medicare Advantage really was the first real attack on Medicare. It used to be called Medicare Plus Choice, and it's almost the same. This was the first major attack, so we should talk about it first. So what it does, Medicare Advantage, is it completely changes Medicare. It introduces the insurance companies and many more between us and the care that we want. So Medicare has to have a contract with each one of those. And then each one of those has to have a contract with every physician and medical group and hospital in the country. So it's already more complicated, and complexity is expensive. And then even more complicated as a cartoon, of course, they tell you, no, this doctor, not that doctor. No, this hospital, not that hospital. So we're paying the insurance companies through Medicare Advantage to tell us which doctors and hospitals we can't use. Why would you do that? Fundamentally complicated. It's in Medicare Advantage that you start seeing the HMO style tools like prior authorization and a few other things where you have to get permission. Traditional Medicare doesn't do that. Medicare Advantage is the ones where you have to get prior authorizations and such. Medicare Advantage, as you can see from my black, green, and red arrows, is the one that gives you smaller networks, a part of the Medicare network. It, for business reasons that we'll talk about, it doesn't want you when you're sick, and it really wants you when you're healthy. That's not a good way to set up a system. It's got a phenomenal overhead and profit. And then lastly, all kinds of issues with fraud going on in Medicare Advantage. And so we'll unpack that a bit. So important thing to know is that it's growing by leaps and bounds, so that depending on how you count them, roughly half of Medicare members today are in Medicare Advantage because they've chosen to largely. Sometimes it's because an employer or other group has put them there, but largely it's because they chose to, and it's nearly half. And the importance of that is that when you go and talk to Congress, they believe that this growth of Medicare Advantage is proof positive of how good it is and how much seniors love it. And so many of them wrote this letter just last year saying how much they think seniors are voted with their feet. And they may as well have said that Medicare is growing, Advantage is growing because seniors love it and it's better. So that's how Congress sees this growth in Medicare Advantage. Terrific human being, physician, Dr. Don Berwick, former administrator of Medicare, has a different take on why it's growing. He said, for example, if an ice cream firm can offer ice cream for free because of a subsidy, well, then its market share will grow against the firms that have to charge for ice cream. It's not because it's better ice cream, it's because it's free ice cream. And indeed, we are massively subsidizing Medicare Advantage over traditional Medicare. And that's the reason that it's been so popular. Medicare Advantage really created the opportunity for profiteers to pilfer Medicare. So if you just look at the overhead piece, which I showed you a moment ago, traditional Medicare's overhead is 2%. Medicare Advantage, it climbs to 15%, sometimes even 18 or higher. So overhead and profit that is not seen in traditional Medicare. How do they do this? They make their money by, I'd say, 4 key ways. The first is fraud, frank, outright fraud, for which they've settled sometimes for hundreds of millions of dollars, or been penalized like that. They seldom go to court and have a settled, and actually have a conviction. So they don't admit guilt, because if they admitted guilt, then they might not be able to participate in the federal program. So that's why you see all the time settled without any admissions of guilt. That's a really important difference. We don't take them to actually a conviction often enough. They cherry pick. They get paid on an average amount for a population per person, but they want the healthiest ones because they still get the average payment, but they don't have the average expense if they can attract the healthiest. That's called cherry picking. That gets them to have a higher profit level. And then lemon dropping, that's what you call it when they take people who have expensive illnesses and try to get them to leave, or try not to attract healthy, sick people. That's called lemon dropping, because your illness is their liability. They don't like that. And then the last major feature that they do is called upcoding, where they get paid for diagnoses that don't need to be treated. So since they're paid by diagnosis, they go out and search for diagnoses. In traditional Medicare, physicians are paid for a procedure, so we put in enough diagnoses to make it make sense. Whereas in Medicare Advantage, the Medicare Advantage firm is paid by the government for diagnoses. So they have really robust systems to collect diagnoses that don't have any real clinical value or need to be documented in a clinical setting. And as a result of this upcoding, billions of dollars are being drained from Medicare. That's no longer going to be available to be used in the trust fund to pay for your dentistry or your hearing aids, because instead that money is being diverted into the profiteers' profits or pockets. So those are billions of dollars just on this one factor, just the upcoding. That's not looking at the fraud or the risk aversion, the lemon dropping and the cherry picking. Just the fraud, just the upcoding is that much. And the way it adds up, they say that they're saving money overall, but it's never been shown to be true. Medicare Advantage has never been shown to save money, according to the Kaiser Family Foundation. In fact, it's always been shown to be worse. And it's big dollars. If you look at the amount of money that we're talking about and compare that to other federal programs that are sometimes under attack, just the overbilling in Medicare Advantage is more than the entire aerospace program. It's more than we spend on the entire FBI or on the EPA. You could combine 2 or 3 of those and not come close. So it's a lot of money. You know, it's hard to know. Is $1 billion a lot or a little on a federal budget? It's a lot. This is a lot of money that they're talking about. And they do it deceptively. So this is a report that came out from the U.S. Senate Committee on Finance a few months ago. And they found that deceptive marketing practices are rampant. And this is just one of the examples that's in that Senate report. It's one of my favorites, because you get a thing like this in the mail, it looks like you're getting something from the government, and you better pay attention. It looks like a tax form, and you better pay attention. You better fill it out, and you better send it back in, because it looks like it's a tax form, and it's not. It's not. It's a Medicare Advantage enrollment form. So we see all the time people say, I don't know how I got into Medicare Advantage. It's through shenanigans like this that are rampant, according to the U.S. Senate Finance Committee. And so we know that about 1/3 of people, when they're trying to decide between Medicare or Medicare Advantage, rely on an insurance agent, and they have one that they think they can trust, because they all tell you, oh no, I take care of all, I sell all insurance products. You can trust me. You know, I'm agnostic about which insurance you pick. They all say that, horse pocky, as they say. And here, look at how the finances work. If you look at the commissions for Medicare Advantage, insurance brokers make $500 now, or probably more. This is 2 years old. $500 for getting you to sign up for Medicare Advantage. If you sign up for a Medigap after talking to them, they get a little more than half of that. So the insurance agent has strong vested interest in this when you talk to them. And then if you look at Part D, the insurance agents don't get very much, which is why the insurance agents often won't spend their time with you to pick out your Part D plan, your drug benefit plan. They'll just tell you to go to Medicare.gov, where it's actually pretty easy to figure it out. Well, they could do the same thing with Medicare Advantage, because it's the same website. So they could tell you to go there, but no, they want that. You know, that's a big juicy commission. And you have to understand too that this is just the first year commission that they sign you up. It's the gift that keeps giving. They'll call you once a year and say, hey, how you doing, Bob? You know, thanks. Yeah, everything good? Yeah, everything's good. Yeah, how's the wife? You know, they'll talk to you for a minute, you know, handshake you, promise to go get a burger, and then every year they keep racking in a commission from you for at least 10 years. So this is a heck of a gambit that they have, you know, if they build up their book of business. So they're not neutral. And like I said, 30% of people signing up for Medicare, enrolling in Medicare, turn to an insurance agent for advice. And it's not as good as you might think. CMS themselves did secret shopper calls of insurance agents last year. Medicare themselves. CMS is the Center for Medicare and Medicaid Services. CMS is Medicare, essentially. So I might slip and say CMS instead of Medicare, but it's the same thing. So Medicare did secret shopper calls themselves and found that the overwhelming majority of them were either inaccurate or insufficient. And here's just my favorite. One example of many we could have picked. Don't worry, you know, you call up your agent and they say, hey, you know, what about my drug? You know, I'm on this expensive drug. It's not on that formulary. You know, I don't want to go into that plan. They say, oh, don't worry. If your drug's not on the formulary, your doctor will just tell the plan and then they'll just add it. And we all know that's just ridiculous. That's not how that works at all. And then lastly, they have these secret rules. You know, Medicare has rules of what should be covered and what shouldn't be covered, what's medically appropriate. Medicare has robust evidence-based rules about that. And Medicare Advantage plans work within those rules, but narrow it down. And so they frequently reject things that Medicare would have said was necessary. So 13% of the time that Medicare Advantage plans deny requests for things, Medicare has determined that those things would have been approved if you weren't in Medicare Advantage. And if you go and get something and then they deny payment for it, 1 out of 5 of those payments, if they refuse to pay for, are things that Medicare would have said, yes, you should have paid for. So they create these secret proprietary coverage rules that aren't in Medicare. And that's so quaint. 2019 was when this data was created. Now in 2000, I'm sorry, I took out now we have, of course, artificial intelligence is creating the rules for this. So this was stuff that was created by humans, and now artificial intelligence is creating these secret coverage rules. So, good luck arguing against that. So if there's all these problems, why do people sign up for it anyway? Well, people sign up for Medicare Advantage because Medicare, traditional Medicare, is flawed. It was set up with some limits, some imperfections, which we're going to explain why in a moment. But first of all, in case you don't know, for outpatient care, you have to pay for 20% of all the outpatient care that you get. You have to pay $1,600 if you go to the hospital. There's no limit to how much this can add up to. So, 3 hospitalizations, you're up to $5,000 that year. If you're sick, then you got to pay for 20% of your office visits. I mean, you go bankrupt. So Medicare, traditional Medicare comes with, premiums that you have to pay for these things. So this is enough to bankrupt people if they don't do anything. So that creates a niche for profiteers. So Medicare members have really 3 choices. The first is to not do anything and struggle with the risks of bankruptcy. And they would, anybody who doesn't have a solution and you're in traditional Medicare, you have a problem. So that's one of the main reasons, as I'll show you, that people give up their traditional Medicare and go into Medicare Advantage. But the third choice would be to buy a supplement, a Medigap policy or a Medicare supplement. Those are synonyms: Medigap, Medicare supplement, Plan G. Those are essentially synonyms. So they think that one choice is to buy a Medigap policy, which you might or might not be able to do. So what's the difference between buying a supplement versus going into Medicare Advantage? Well, the premium is one thing. So if you want to buy one of those supplemental policies, and Plan G is the one that you would probably want to buy in 2023, if you buy one of those supplemental policies, you'll spend about $200 a month. You can go into Medicare Advantage. Here in Missouri, you can go into Medicare Advantage for free. The average around the country, all told, is about $18 a month. So $200 versus $18. That's really where this chart could stop. The out-of-pocket differences are also pretty striking, though. The out-of-pocket differences for Medigap plan, you really have no out-of-pocket expenses for covered benefits once you've hit that deductible. So that's good. Medicare Advantage, this is what the dirty little secrets they don't tell you. Medicare Advantage, your out-of-pocket expense could be $12,000 if you have to go to someplace, Scottsdale for some healthcare that they don't have, where you live. That's a big difference that you don't think about because you think you're not sick. Medigap doesn't add any benefits. Medicare Advantage, so you just have the benefits. You don't have hearing or vision. You buy Medigap. Medicare Advantage does offer these extra perks, gym clubs and hearing and vision. But if you look at the financial value of that, it's usually pretty limited. I think it adds up to a total of about $2,000 a year of value if you used everything, and nobody uses very much of this. It's bottom end eyeglasses. It's very limited dental care. So it's not as much as it's not as attractive as what they would want you to think. If you have Medigap, you can still have the entire traditional Medicare network. If you have Medicare Advantage, you have to stay in network if you want robust coverage usually. And with Medigap, it's pretty. They don't add any prior authorizations or any of that other nonsense from HMOs. Whereas in Medicare Advantage, that's where you run into it. So that's several more lines of differences. Some favor Medigap, of course, but the one that people really stop looking after is that first one. You're looking at $200 a month versus $18 a month, or like I said, free. And so what most people think when they're turning 65 is, I'm going to start with a free Medicare Advantage plan, And if that stuff that wacky Dr. Weisbart had to say to me turns out to be true, and I'm worried about it, well, then I'll pay the extra. Then I'll pony up and I'll switch out and go into Medigap if Medicare Advantage won't let me do what I want to do. And what they don't know is that they might already be trapped. If you decide to go into Medicare Advantage and you stay there for more than a year, you might very well be trapped there and not be able to go back into traditional. You can always go back to traditional Medicare, but you may not be able to get the supplemental policy that you need. And then you are essentially financially trapped or risking bankruptcy. So there's these two protections that we've all learned to expect because of the Affordable Care Act. The Affordable Care Act really institutionalized these two consumer protections in the insurance world and health insurance, and that these are protections that exist in the Affordable Care Act marketplace that people don't realize disappear once you turn into Medicare age. You join Medicare and you still have these protections for the first 6 months that you're in Medicare or 12 months that you're in Medicare Advantage, and then they disappear. So the first is the requirement called guaranteed issue, that the insurance companies have to sell you a policy, essentially eliminating pre-existing conditions. We know that was a big deal with the ACA, and that's a big deal the first 6 months you're in Medicare. For the first 6 months, if you have a pre-existing condition and you want to buy a Medigap policy, they're guaranteed issue. So they will sell you a policy if you apply for it. And there's community rating, that they'll sell it to you for the same price that they sell it to you if they sell it to anybody else in your community. They can't send you a survey asking you if you've got cancer or diabetes. They can't do that because it's guaranteed issue and community rating for the first 6 months that you're in Part B of Medicare or the first 12 months that you're on Medicare Advantage. If you're in one of these handful of states, not Washington, oh yeah, Washington a little bit, then you have some extra protections, but not very much, and certainly not most of the country. So essentially, if you're on Medicare Advantage for more than 12 months, you're probably trapped in Medicare Advantage, and you may have a hard time finding somebody who would sell you a Medigap plan if you decided that you wanted to go back to it. So, this is all crazy. Why do we have this? Why isn't Medicare already perfect? Why was it set up with these gaps? Well, I don't know, but I've got three theories that I've spent the last 2 months trying to figure out. And the first is this concept of the moral hazard versus skin in the game. So there was a lot of talk in 1965 that if you give people unfettered access to Medicare, to health insurance, that the moral hazard is this thing economists say that they will, once they have access to healthcare, they will go get healthcare whether they need it or not. And so there was a concern by some folks that if they made just everything for everybody covered, that would lead to skyrocketing costs, because people would get needless, foolish things. And so the concept of skin in the game, which is just an incredibly horrible phrase to use in healthcare, but skin in the game, if people have skin in the game by having these copays and deductibles built into Medicare, that then they won't be such willy-nilly consumers of healthcare. And I thought Don McCain, a PNHP maven, Dr. Don McCain said this best. He said, we don't really have to worry about unleashing a stampede of free leg amputations or free liver transplants. People don't want healthcare. I mean, if they don't need healthcare, very few people are running in to get stuff. So this whole concept of moral hazard actually doesn't apply. And in fact, there's tons of evidence showing the opposite, showing that when the moral hazard, the extra healthcare people get when they're insured, it's healthcare they couldn't afford until they got insured. And so this just came out today, as far as I believe, where they did a survey asking people, if these things weren't covered by your insurance, would you still go get them? And we know that most people get some of these things every year. There's a nice list here that the ACA required to be covered. We had zero copay, so for free. And so this survey asked thousands of Americans, if you had a copay, would you still go get these things? Most people wouldn't. So these are important things. We want people to be counseled on smoking cessation, and we want to find people who are depressed and try to help them. We want to do these things. And yet most people, if they had to actually pay for it, would say, thanks, but no thanks. So this whole moral hazard, it was one of the things picked around about why Medicare was created with these gaps, these copays and deductibles and benefit gaps, but it's kind of the evidence doesn't fit it. Another theory, which I think makes more sense, was that the insurance industry was not real happy about having all these folks getting covered with a healthcare product that they didn't have part of. And so one of the ways to kind of diffuse the opposition from the insurance industry was to create a niche for them. So indeed, and that's what they did. This created a market for the commercial insurance industry, and it solicited more of their support by limiting the value of Medicare. One of the relevances of that is that people say, well, really Medicare for all, which you probably know is my passion, Medicare for all, don't we want to find a way to protect the insurance industry? Well, this shows us that if you want to find a niche for insurance industry under a Medicare for all model, you can do that. Just make Medicare for all crummy. Make it crummy, and there will be a market for the insurance industry to come into. So, we don't want to do that. That was a mistake we made on here. But I think the real reason that it's pretty hard to find people talk about much is the Southern strategy that, people, white folks didn't want them colored folks to be in the same waiting room with their doctor. There was a lot of pushback about that. Well, if you put in these massive copays on the outpatient side of care, well, then you don't have to be as worried about that, you silly people. I think a big reason why there's the massive copays and deductibles in Medicare was the Southern strategy, also known as racism. And Medigap doesn't really solve that, because Medigap is still, an expensive thing that you have to purchase. So that created this whichever of those strategies was the reason, that created a niche for profiteering. I showed you the overhead of traditional Medicare and Medicare Advantage, outrageously more expensive overhead and profits than traditional Medicare. Medicare supplemental policies are like, it's a closed black box that people seldom look at, but they have even higher overhead and profits. And this got me really sort of aggravated today when I was thinking about that number, that 22%. And I did the arithmetic for myself. So I have Medigap for my wife and myself. We spend about $400 a month, or in other words, we spend about $5,000 a year. In other words, I'm spending $1,000 a year. I'm spending $1,000 a year for nothing but the overhead and profit of the Medicare supplemental policies, because of racist setups of Medicare that required me to have to do that. It's, this stuff affects all of us. It's just crazy. Okay, so that's Medicare Advantage. Here you see it, marching its way along to nearly half. But then traditional Medicare, is actually a bigger opportunity still for the investment community. The investors are obviously really happy with Medicare Advantage, but traditional Medicare, as you heard Karen start to talk to, is at least as big of an opportunity. So here's my cartoon of how it works today. There's Medicare Advantage and traditional Medicare, and it's roughly 50-50. And so Medicare Advantage is risk-bearing profiteers. I think that's a fair word to use, given their overhead and profits. And traditional Medicare is really, they just have some administrators with living within the 2% overhead. And this new concept of ACO Reach, formerly called DCE, this Medicare has declared it wants to have everybody from traditional Medicare in an outfit like ACO Reach by the year 2030. Everybody by the year 2030 in ACO Reach or something similar. There is cause for hope, which I'll tell you in a moment. But the plan from Medicare was to have everybody opt into one of these things. So what is ACO Reach? It's, as I choose to call them, new profiteers within traditional Medicare. Medicare is assigning people to your doctor's reach if your doctor's in one. They're not asking you, they're barely telling you, and they're assigning you to one of these. So you may be in one today and not even know it. You might have been told. And then Medicare prepays that new for-profit profiteering outfit called Reach ACO for a range of services that they've agreed to. So they're paying them. And so that means the less service you get, the more profitable the Reach becomes. That's the opposite of how you want a healthcare system to go. So the less healthcare you get, the more profitable. And not to worry, if you're unhappy about that, you find out you're in when you get one of them letters and you don't like it, you can call Medicare and tell them to let you out, and they'll tell you you can't, because you can't unless you find that you want to get out. Sure, just find a new primary care physician. They may not even tell you that, though. They may tell you, not a problem, we'll let you out. You can opt out, and we'll send you a letter confirming that. I got one of these today from somebody, and they got, oh, you might have one too. And you get a letter saying that you've opted out of having your data shared. with the ACO Reach, not your money, not your money. So you can't get out. You cannot get out of these once you're assigned unless you choose to find a new primary care doctor. It's happening without any oversight or approval by Congress. So we've already got 2 million Medicare members that have been automatically assigned as of currently. And like I said, Medicare announced that they wanted to have everybody in one of these things or something like them by 2030. So groups like PASARA and Physicians for a National Health Program have led the charge on getting people aware of this and fighting against it, this profiteering takeover of traditional Medicare. And as a result, just a few weeks ago, Medicare announced that due to the public outcry, that they were going to close down enrollment to it, no new ACO Reach entities. It's going to end in 2026. And the 2.1 million people that they've assigned to it, they're not expecting it to grow. So remember, this was on track for 30 million people by 2030. And now it's going to end and have only 2 million people. So, hooray. Now, the game is not over. The game is not over, which we will talk about in a few more minutes. So, we still need to, watch and fight this thing. But the idea is that privatization diverts money to these investors. So I showed you these numbers. I showed you how outrageous it seems to let Medicare supplemental policies have this kind of overhead and profit. Medicare Reach is even worse. Medicare Reach is even worse, where if you look at the way their finances are set up, they're allowed to keep every penny of the first 25% that they don't spend on healthcare. They can keep first 25% of that on overhead and profits for themselves, and more if they go even more egregious than that. I don't know how many of them will achieve this 25% number, but the contracts they have allow them to do that. That's just, why would we want to do that? Why would we want to do that? So we need to not do that. We need to stop privatization. We need to stop it and drive it back. And so there are two key high-level strategies I think we need to adopt. The first is what I choose to call sour the milk for Medicare Advantage. Souring the milk. What does that mean? Don't let them make this kind of crazy money off of it. Sour the milk that attracts them. So in a whole suite of tools, eliminate all of the Medicare Advantage overpayments. If you eliminated that, there wouldn't be a business case for the investment community. They should not be able to use secret rules that deny you access to things that Medicare has said is medically important. They should be required. You shouldn't have to give up doctors in the rest of the traditional Medicare network because you have opted into this crazy model. So Medicare, they should not be able to do that. And then, if we have these fraudulent entities, they should not be allowed to participate really in anything, but certainly not in Medicare Advantage. So doing these things would, in my mind, sour the milk and make Medicare Advantage less attractive. But wait, there's a problem with that as a single leg of a strategy. The problem is traditional Medicare has some pretty major flaws. People are sometimes going into Medicare Advantage naively, but sometimes they're going into it with eyes wide open because, the copays and the deductibles and the lack of benefits that we don't have in traditional Medicare. So if you just did this, that's not good enough. Souring the milk is one of the two legs of the strategy. The second is I think we need to sweeten the juice of traditional Medicare. That may not be the best way to describe it, but sweeten the juice of traditional Medicare. And that means expand the benefits. Who doesn't think their mother or grandmother should have hearing if they need it, or vision, or get their teeth fixed? Expand the benefits in traditional Medicare. You shouldn't have to join Medicare Advantage to get access to a dentist. That's just not right. There should be you shouldn't have to spend as much money as you do on out-of-pocket expenses. There's no limit on out-of-pocket expenses. So put in a limit, for crying out loud. Put in a limit to how much you have to spend if you're in traditional Medicare, and then make sure that Medigap is affordable and is accessible and is guaranteed issue to everybody. So these are the two legs, I think, of a core strategy: sweeten the juice of traditional Medicare and sour the milk for Medicare Advantage. So that means that we saw Medicare announce a few weeks ago that they're not going to grow Medicare or the Reach program any further. Well, we demand that they keep that. We demand that they hold to that. We need to watch for that. We need to keep an eye on that, and we will be. We are. watching for that. We need to make sure that Reach indeed does not grow, and we need to make sure that Reach doesn't metastasize. So one of my fears is that what's going to happen instead of Reach growing, because they know that we know about it, public outcry was the reason they froze it. So instead of Reach continuing to grow to 30 million, it'll stay at the 2 million, but the little parts of Reach, the little bits and pieces will be sprinkled through the rest of this. So we need to be vigilant to see what else is going on and watch for any signs. Look for Reach 2.0, or look for Reach being broken up and sprinkled around, the things that we don't like about it. And then lastly, we need to protect traditional Medicare, because our goal, my goal, PNHP's goal is to have Medicare for all, or something of that sort, a single payer universal healthcare system. And traditional Medicare remains the most sensible way to structure that, unless the profiteers destroy it, in which case then we have a problem. So Medicare was enacted against a whole lot of opposition. The insurance industry, actually physicians, a whole lot of groups didn't want Medicare to be passed, and yet it was. And we should hang our hat on that, on knowing that we can actually accomplish a lot. Our opposition is formidable, but as our good friend, PNHP staffer Dixon said, it's formidable but not invincible. So we can win this. Last thing just to say, if you're not familiar with it yet, you can get a lot more information on Reach and on Medicare Advantage by going to this nifty little website that PNHP set up called protectmedicare.net, not .org or .com, .net, protectmedicare.net.